Hello, I'm Josh Tarini, Senior Clinical Specialist with Medtronic Diabetes, and I'd like to welcome you, whether it's your first time joining us or whether you're coming back to our Medtronic Diabetes webcast education sessions. My pleasure to be here today. Our topic is practical keys to CGM, or continuous glucose monitoring, and I have our expert panel of speakers beside me. Dr. Margaret Lawson, pediatric endocrinologist from CHEO, Children's Hospital of Eastern Ontario, and Christine Richardson, registered nurse and certified diabetes educator, also from CHEO. As I said, our title is Practical Keys to Successful CGM, which I think you'll find most helpful for your practice. And our discussion today demonstrates the commitment of Medtronic Diabetes to ongoing continuing education and learning to offer you relevant and practical tips and information for your practice. While the content today does have a pediatric focus, I think we would agree that it'll be equally applicable to those of us who practice in an adult environment as well, and for those patients that we see. In front of you, you'll be able to see both our smiling faces as we present this morning, as well as the slides that you should be able to get up on the screen and follow along as we go. So I will ask you to enjoy the webcast and stay tuned for further iterations as well. And before we proceed, I'd like to take this opportunity to introduce our first speaker, Dr. Margaret Lawson. Dr. Lawson is a pediatric endocrinologist at the Children's Hospital of Eastern Ontario, CHEO, and a professor of pediatrics at the University of Ottawa. She describes herself as an early adopter of diabetes technology, insulin pumps, and CGM, and is passionate about the positive impacts it has had on families. She is the principal investigator of the JDRF CCTN Cgm Time Trial, which is a multi-center RCT evaluating the timing of initiation of CGM in children with established diabetes starting insulin pump therapy. So without further delay, I will turn it over to Dr. Lawson.
Thank you, Josh. I'm pleased to be here. So I'd like to begin with my conflicts of interest, disclosure of them. I have spoken previously at educational events sponsored by Medtronic and Animas, and previously participated in a Medtronic advisory board. I have a personal policy of accepting coverage of travel expenses only if I have no other reason for attending these meetings or events, and I also don't accept speaker or consulting honorariums, including for this webinar. I do lead an investigator-initiated multi-center study, which uses Medtronic pump and CGM devices. That's called the Cgm Time Trial. And supplies for the pilot study were provided by Medtronic Canada, with supplies for the time trial being purchased at a discounted rate from Medtronic. So the objectives for my part of the webinar are to demonstrate how CGM can address challenges and limitations of current diabetes management, to identify candidates that can benefit from CGM use, to describe strategies that help people use CGM more effectively, and to demonstrate how CGM data management software enhances diabetes clinic visits. So I'd like to begin by telling you about a patient of mine who made me into a very strong advocate for CGM. I'll call her Ashley, and she was a 14-year-old at the time who'd had type 1 diabetes for 4 years. Had recently transitioned to MDI with glargine because she had suboptimal control with an A1C of 8.4%. The challenge was that she was a competitive athlete and she had repeated hypoglycemic seizures. And even with MDI with glargine, she continued to have suboptimal control and to have continued to have seizures. And in particular, if you look here at her CGM tracing, you can see that the family was keeping her blood sugars higher than desired at night because of their fear of hypoglycemia and her recurrent seizures. She was scheduled for a pump start in hopes of optimizing her control and decreasing her seizures the same week that CGM was approved by Health Canada for commercial use. Canada was the first country in the world to approve it, ahead of the US or Europe or Australia. And so Ashley became the first person in the world to use commercially available CGM. And the experience that she had with this turned me into a very strong advocate for CGM. It was the easiest pump start I'd ever done, and 6 weeks later, you can see here the kind of control that Ashley had achieved. She had an A1C that had dropped to 6.1%, hypoglycemia was rare, and in the next 2 years, she maintained excellent control with A1Cs in the 6s and low 7s with no further seizures. Now, I'm a strong proponent of CGM, but I know that not all my colleagues are, nor all patients. And what do they say about it? Well, they tell me it's too technical, that it's too expensive and insurance won't cover it, that it's too much effort, that it's not accurate enough, and that they don't know what to do with all that information up to 288 readings per day. And I would remind you that initially there was skepticism about home blood glucose meters. when they were first introduced in the 1970s, people said who, why, and how will patients ever use this technology? Will they be willing to carry a meter with them everywhere they go? Will they be willing to spend 80 cents for every single blood glucose test? Will they know how to interpret the information and not to put too much reliance on a single blood sugar and recognize that it may not be the same as a lab glucose? And the arguments against home blood glucose monitoring included that the meters are too big, the strips require too much blood, the lenses are too painful, and the strips and meters too expensive, they're not accurate enough, only within 15 to 20% of a lab glucose, insurance won't pay for this unproven new technology, and how do we learn how to use these results and teach our families how to use it? But I would ask you to think back and wonder what would have happened if we hadn't adopted SMBG with all its limitations, some of which still exist today. We certainly would not have had the DCCT, and a generation of patients would have suffered complications as a result of lack of SMBG and the data that came from studies like the DCCT. The DCCT also paved the way for clinical practice guidelines and A1C targets. And in Canada, we've based our adolescent targets on the DCCT findings. And in school age and younger kids, we've progressively decreased the A1C targets to try to optimize control. In contrast, the ISPAD has gone to a single age-based target, a single target for pediatrics of less than 7.5%. And the Americans recently went to this, adopting the 88 target. And the reason they did this was based on some studies, in particular those done by the T1D Exchange Clinic Registry, which is a study of over 13,000 children and youth with type 1 diabetes. And they looked at the proportion of these youth who met the 2012 age-specific ADA A1C targets. And you can see that it looks pretty good for these less than 6-year-olds, that when you set a high target, it's not that hard to reach, and similarly for the 6 to 12-year-olds. But for the teenagers, only 21% of them met that A1C target. And if we compare to how they would have done if you looked at the 2014 ADA target or the ISPAD target of less than 7.5 for all age groups, then across the board, we're not doing an adequate job in pediatrics. Most of our patients are not reaching the A1C targets required to keep them healthy in the long term. And why is that? Well, it's not because of lack of effort. They're using better insulins, pumps, and MDI more than ever, and they're putting an awful lot of effort into diabetes management. And this study, again from the T1D Exchange Clinic Registry of over 20,000 individuals, looked at the frequency of blood glucose testing in relation to control. And what they showed was that 69% of the patients had A1Cs that were suboptimal, greater than 7.5%, but they were doing an awful lot of SMBG checks. In fact, the school-age children were checking their blood sugar at least 5 to 10 times per day in more than 84% of them. And more than 50% of the teenagers were doing blood glucose checks more than 5 times per day. But that wasn't enough to optimize control, because SMBGs just give you that snapshot, that intermittent look at what's happening, and not enough information to fine-tune insulin delivery, whether it be by a pump or MDI. In addition, we had this limiting factor of hypoglycemia, which plays a major role in families achieving the A1C targets. We know that those who have greatest fear of hypoglycemia have higher A1Cs, and that they engage in hypoglycemia avoidance behaviors that further increase their A1C. Parents of T1D children report that poor sleep has a major impact on quality of life for them and their children, and on school performance and daily functioning. And parents report doing regular overnight SMBG, in this study 41% of the time, and I say amongst my parents, the majority of them are getting up, if not every night, to check their child's blood sugar, then certainly several times per week, in order to enable them to sleep through the night and know that their child will be safe through the night and in the morning. So how can CGM address these challenges of current diabetes management, the issues around hypoglycemia, as well as failure to achieve A1C targets? Well, before looking at the evidence, it's important to recognize that there's problems with interpreting it. And the challenge is, when you look at technology which has advanced rapidly over the last number of years, then how do you interpret the published studies in the context of current technology? The studies that we look at use the earlier versions of CGM, which are not available today because they've been replaced by better, more accurate, more user-friendly devices. These studies used sensors that only lasted 3 to 5 days, as opposed to the 6 to 7 day sensors available now. The earlier versions of Medtronic's Dexcom and Freestyle sensors were less accurate and more painful than the ones available today. And the earlier versions of pumps didn't include features like the low glucose suspend feature from Medtronic's pump with Veo, as well as they weren't integrated with CGM in the case of the Dexcom sensor. And so I and others would argue that you can't evaluate current technology on the basis of studies of outdated technology. If we wanted to look at the impact of personal computers on our daily lives, we wouldn't look at evidence or information from the Commodore 64 and how it impacted our lives. Instead, we look at the computers that are available today, such as the MacBook Air and other laptops and desktop computers. Similarly, for SMBG technology, and for pump technology, and for CGM, the pace of advancement has been even more rapid. As you can see here, in the last 8 years, we've gone from devices which were large and had some definite challenges in terms of user satisfaction to ones which are dramatically different. And you can't compare these two devices in terms of their effectiveness or satisfaction and patient use. John Pickup, who is a renowned endocrinologist from the UK, has argued this. And said that if you're looking at evidence for diabetes technology, you need to be very careful about you're looking at RCTs and meta-analyses, because the conclusions may be inappropriate and often misleading because they use studies involving outdated technology. In addition, the people who volunteer for RCTs are different than those who are in the general clinic population, and the results may be different in terms of their experience with the technology. Observational studies, he argues, may provide more meaningful data. They have larger numbers, go on for longer duration than an RCT, and the participants are likely more representative of the patients likely to benefit from technology. Having said that, when you look at the studies that have been published, even in those earliest versions, those early prototypes of CGM, there was a positive impact on A1C as long as it was used frequently and consistently. And the JDRF CGM study group, which was the first landmark study evaluating this, showed that more frequent use of CGM improved A1C across all ages when it was used at least 6 days a week. Looking at the STAR3 study, which randomized individuals to stay on MDI or start sensor-augmented pumps, so pump with CGM, those who were randomized to start a sensor-augmented pump over the course of the year had a lower mean A1C in both pediatric age groups compared to those who continued with MDI. Further, if you look at those who met A1C targets, a higher proportion of those randomized to sensor-augmented pump achieved A1C targets in both the school-age population and the teenagers, compared to those who stayed on MDI. Looking at clinic experience, again going back to a T1D Exchange clinic registry study of over 17,000 participants, they looked at those who used CGM by self-report at least over the last 30 days, and 9% of them had, so a small proportion, but those using CGM had a lower mean A1C in both the children and the adults, and a higher proportion of them achieved A1C targets, as evidenced by the lower median A1C in all the age groups. The Italian experience is similar in this retrospective study in which they compared 129 children and youth who were on sensor-augmented pump for anywhere from 6 months to 3 years to almost 500 who stayed on standard pump therapy, and showed a decrease in A1C in both groups, but a significantly greater decrease in A1C in those who went on sensor-augmented pump. None of these studies looked at low glucose suspend, the newest feature of CGM and sensor-augmented pump. And so when you see here from the CareLink tracing that an individual who wakes up with a blood sugar of 5.4 can feel very confident about the morning blood sugar, but what they're not aware without CGM is what happened during the night. And if you look at the CareLink tracing from overnight, you see that this child had blood sugar that began to drop around 2 a.m., not uncommon in many children, which is why their parents get up to check them during the night. But thanks to the low glucose suspend feature, the pump automatically suspended insulin delivery for 2 hours, allowing that blood sugar to rise slowly and carefully into a safe range by morning and preventing what could otherwise have been a serious life-threatening hypoglycemic episode. So several studies have examined the effect of low glucose suspend on the frequency of hypoglycemia compared to standard pump therapy without low glucose suspend, but with CGM, and shown that if you have been using low glucose suspend, there's a significant reduction in the frequency of moderate and severe hypoglycemia. As well, a decrease in the amount of time, both daytime and overnight, in the percent of hours with glucose less than 3.9 without an increase in A1C. In addition, when you look at patient-reported outcomes, we see a significant improvement. The Hypoglycemia Affairs Survey is the most widely used patient-report measure to examine how patients feel about hypoglycemia and the impact it has on their life and diabetes management. And it's been well validated as a good measure of hypoglycemia feelings and fear. And this showed that when low glucose suspend was used in these subjects, there was a significant decrease in the total hypoglycemia fear score, as well as in the behavior score and worry score. So patients felt better and were happier and less worried when they had low glucose suspend activated. So that's a patient-reported outcome, which people recognize is an incredibly important aspect of looking at any outcome from an intervention in diabetes, because you need to examine the patient experience. The challenge is looking at the evidence regarding this. This study was a clinic-based series which showed an effect on hypoglycemia fear. But if you're looking at RCTs, they're powered for metabolic outcomes, which means they don't have the sample size required to detect a difference in patient-reported outcomes. In addition, as I said previously, people who enter clinical trials usually have better quality of life. That means they may have decreased potential for benefit for on-patient-reported outcomes. And observational studies and clinical experience may provide more meaningful information on what it's like for patients experiencing these technologies. But when we look at the studies that have been done, whether they be RCTs or other kinds of studies, they show that when CGM is used, what patients report is higher quality of life and treatment satisfaction for youth and parents. Insulin adjustments are easier and parents feel safer. Parents and teachers report increased comfort in the classroom. There are fewer missed school days and decreased hypoglycemia-related anxiety. So in summary, CGM effectiveness through a variety of different studies has shown that when CGM is used at least 60% of the time, it results in lower A1C, people more likely to reach A1C targets, decreased frequency of hypo and hypoglycemia, decreased moderate and severe hypoglycemia when low glucose suspend is used, and improved patient-reported outcomes. The challenge, however, is that most clinical trials show suboptimal CGM adherence in the pediatric population. So how do we get children and youth to use CGM to the extent required so they can achieve these benefits that have been demonstrated in adults and in RCTs where children have used it well? Well, initially when we started using CGM, it was much like when we started pump therapy back in the late 1990s, and we targeted those most likely to succeed. So those likely to wear CGM at least 60% of the time, those likely to use the CGM results to look at and react to the numbers in real time, and those who were going to use data management software to proactively make changes in diabetes management and behavior. But if we do that, we're targeting those who are likely to succeed, but we're really failing the other patients, and the more than 70% of patients who are not reaching A1C targets and not having adequate control. So instead, I've changed our approach, and the approach that I use and my colleagues at CHEO, in that we now try to target those who are most likely to benefit, which include pump and MDI users who are not reaching A1C targets, which is anywhere from 60 to 70% of our patients, those who have frequent hypoglycemia, and those who have fear of hypoglycemia or a pattern of hypoglycemia avoidance behaviors that are having a negative impact on their A1C as well as their quality of life. And then focus on factors that will make these individuals successful, those that influence CGM adherence and effectiveness. And those include human and technical elements as well as education and support. So the human elements required for CGM success include having realistic expectations. That means debunking the myths associated with CGM. It doesn't mean no more glucose testing. It's not easier than using SMBG alone. And recognize that success requires frequent use in order to achieve the benefits. Education and support from healthcare professionals are absolutely key. It's very hard for a patient to adopt any technology and use it successfully if they're not getting positive messages and support from their healthcare practitioner. In addition, we learned the hard way from the early days of CGM the importance of education upfront, of providing good tools and support, and with constant reinforcement in order for people to be successful with CGM, the same way it is with other aspects of diabetes management. We wouldn't give someone a meter and send them home and a diagnosis of diabetes and say, figure out how to use it, start recording blood sugars in a book, hand them an empty book, and then adjust your insulin on your own without giving them some guidance and support and regular check-ins, and the same is required with CGM. In addition, without support from a healthcare professional, it's very hard to get reimbursement from insurance companies because letters are required to justify the medical necessity at this point, and that involves work for the family and support from the healthcare professional. We did a qualitative study back with some of our early users of CGM, the early adopters, to see if we could learn from them why some were very successful with CGM and some struggled. And we divided them into these two groups and then compared and contrasted some of the differences between them and what made people successful. And what we learned was that those who were successful had, the parents and the youth together had developed shared and realistic goals. They were prepared for the workload of CGM, and they shared the responsibility. They viewed CGM as a second pair of eyes, not as someone spying on them or finding out information about their teen that when they weren't around. And they initiated CGM at the right time. And people have questioned that in a number of different studies. The Onset study examined whether CGM was best initiated at the time of diagnosis. The JDR CGM study group and several others have focused on experienced pump or MDI users, believing that it's better if someone is comfortable and experienced with their insulin delivery system before adding CGM. And then a few people, including us, have examined whether it's better to start CGM at the time of pump initiation. And there's clearly pros and cons to both. So if we look at delayed initiation, which is when CGM is added to pump therapy, the potential advantage is that CGM education may be easier and more effective, both for the patient and the educator, because you can focus on a single technology. However, the downside is that CGM may be viewed as an optional add-on, something to be used intermittently or only in times of trouble, as opposed to the consistent use required for effectiveness of CGM. In addition, we learned from our qualitative study that some individuals in whom CGM is added to pump therapy felt that it added to the burden of care. It took away from the freedom they experienced at the time of starting pump therapy, but with the steeper learning curve and without the immediate benefits they saw with pump therapy. In contrast with simultaneous initiation, when CGM is started with pump therapy, do individuals view CGM as an integral and essential part of pump therapy where you wouldn't use one without the other? And our families more prepared to make and sustain behavior change because they've chosen to start pump therapy. They know it's going to be work involved and effort. They've made time for that, and they expect there to be a benefit, and they're willing to put in the effort required for that and the behavior change. On the downside potential, though, is it harder to learn about pump and CGM at the same time, and which method is better? So to examine that question, we designed a trial called the Cgm Time Trial, which is a multi-center study involving 5 sites in Ontario led through CHEO, which uses the Medtronic Veil with low glucose suspend, Enlite, initially under investigational testing authorization from Health Canada until it was approved, and iPro 2. The participants are 5 to 18-year-olds who were naive to pump therapy, all scheduled for a pump start. And then 144 of them were randomized to start simultaneous pump therapy, pump with CGM, or standard pump therapy with later addition of CGM at 6 months, with follow-up in the main study to 12 months and an extension to 18 months. And we're currently analyzing the 12-month outcomes. This study is funded by the Canadian Clinical Trials Network and FedDev Ontario, for Southern Ontario, and the Government of Canada, support from them, and is underway, and hopefully we'll have results to report on that soon. So going back to the elements for success, there's some technical ones which are really key, as with any technology. So calibration is very important. It can be a challenge for families if they're not instructed and supported in proper calibration technique. So timing is very critical with the Medtronic sensor. It does require stable sensor glucose, which means no trend arrows at the time of calibrating. And the calibration schedule and frequency needs to minimize cal reminders if people get annoyed and frustrated with the device. So setting that up for success is really important. It's important to turn off auto-calibrate so you know that the sensor, the blood glucose that's being used to calibrate is an accurate glucose and one that's not rapidly changing. And that brings us to the importance of accurate SMBG results. And when we're focusing on CGM, we focus a lot on the accuracy of CGM, but I don't think we pay enough attention with families to the importance of getting an accurate SMBG reading. And the accuracy of CGM is only as good as the accuracy of the input to it, which is the SMBG result. And this is an interesting study back from 2011, which looked at the importance of hand washing with blood glucose testing. And clearly we teach this to our families, but we know, at least in pediatrics, that a lot of kids don't do it, no matter how often we ask them to and stress the importance of that. So what they did in this study was they compared the accuracy of using a first versus a second drop if you didn't wash your hands, and compared to a gold standard, and showed that with using the first drop for an SMBG without washing, that 11% of the blood glucose tests were more than 10% different than the standard. So if you're using that for calibrating, you're not going to get an accurate CGM result, a CGM correlation. In contrast, if you wiped off that first drop and used the second drop, then only 4% of the blood glucose readings were more than 10% different. They went on to this in this experiment, and they actually had the participants expose their fingers to fruit. They handled fresh fruit, and then they tested their blood sugar, and the difference, as one would expect, was even greater. So fruit-exposed fingers had a more than 10% difference in the reading from control, 88% of the time with the first drop, and that dropped to 11% with the second drop. So clearly the message here is that ideally wash your fingers before you test blood sugar, but get in the habit of always using the second drop, and then whether the finger is clean or not, you're going to get a more accurate glucose reading, and with that a more accurate calibration and better correlation and accuracy of CGM. We also know that long-term CGM leads to greater CGM accuracy. And if you see here, this was from someone who had just started on CGM and was having challenges with correlating and with doing calibrations, and in fact didn't do calibrations in the required time, and so got to the initial readings were quite good through the overnight. It looked like it was going well at the day, and then hadn't calibrated, tried to calibrate in the afternoon, and at that point, when tried to calibrate, the blood sugar was rising, couldn't get an accurate calibration, alarms started going off, and then it's very hard to get a good calibration once the blood sugars have risen like that and it's not stable. Whereas when someone's blood sugars are stable, so within a week or two of pump therapy, when the insulin settings are well adjusted to what their needs are, and you're getting good blood sugars within target range most of the time, it's easy to get good calibrations and to see really good correlation between the SMBG reading and the CGM. This was also shown in a nice study presented at the ADA last year, who looked at, Jennifer Castle looked at 84,000 Enlight sensors from 729 continuous users across the US, and showed that as they use CGM up to 20 weeks, the accuracy improved significantly. So people get better at using it. As they use the CGM results, they are able to make adjustments in their insulin therapy. They get better blood sugar readings, better calibrations, and better CGM accuracy. Other technical issues related to CGM success include tape, and can be an issue, much less so with the new Enlight just approved, the enhanced Enlight, which is a better adhesive patch. But with education support from nurse educators, a personalized solution can be found for all individuals, and because there's so many different products on the market that can be used to find one that works for each individual child or adolescent or adult. Sensor location is also important. Depends on the individual. Enlight is approved for abdomen and buttocks, but the position of the sensor is quite susceptible to a sleeping position and the performance of it. And that was shown in a nice study where they showed that pressure on the sensor overnight, if you're sleeping on it, can lead to false low glucose suspend readings. And this was shown in one of our patients, where you can see here the sensor is quite stable through the night, and then you see this sudden drop around 6 in the morning, where it looks like the glucose drops precipitously, which would not be expected or explained. That triggered a false glucose suspend alarm, and the blood sugar rose when the individual didn't check their blood sugar and confirm that it truly was low. And so we advise our patients to make sure that they choose a sensor location that is away from the place they usually sleep. I mentioned earlier the importance of education and ongoing support. There's a nice module with Medtronic's My Learning, which is online and available in French and English, and has a really nice stepwise approach to learning CGM as well as other aspects of pump therapy. And we encourage patients to use this at home. They can print out a certificate demonstrating they've done that, and then come in for an individualized session. The alarms is another key thing in setting up the menu for CGM success. And again, we learned this the hard way in the early days of CGM, where because Health Canada approved it before other countries, we didn't have teaching materials, we didn't have experience, and people thought more was better. And you've got all these alarms, why not use them? And in fact, that led to frustration and alarm fatigue, and people not continuing with CGM. And so for the time trial, as well as in our clinical practice, we've learned which settings need to be activated at the beginning, and how and when, and to activate them down the road. And this is published in our time trial manuscript about the design of the time trial in BMC Pediatrics, so you can see the full settings there, but I'll draw your attention to just a couple of them. First is that alert settings are not the same as glucose targets, and too many patients think that if my target is 4 to 8 or 4 to 7, well, that's what the alert should be. And if that happens, we know it's going to be alarming all the time. The alert settings should be at a point where you need to be notified and action needs to be taken now. So for example, for a child under 12, we recommend setting that at 3.6 is the lower limit and 17 is the upper limit, a point where you'd need to take action to prevent acute harm. We also recommend not using any alarms in the beginning except for low glucose suspend. Again, if you're doing this with a simultaneous start where you're starting pump therapy, you know it's going to take a week or two to get those pump settings established and customized to what that child needs, and that the glucoses are not going to be perfect or in target range in that time. And you don't want the alarms going off unnecessarily and causing alarm fatigue. So just low glucose suspend initially. And calibrating, as I said before, when sensor glucose is stable and ensuring the auto-calibrate is turned off. This is an example of inappropriate alerts and settings, where you can see here, first of all, that low glucose suspend is working well. It's set at 3.0, and that's an appropriate setting. And when suspension led to a rise in blood sugar to 8.2 in the morning. But the targets otherwise are, the alerts are set too tight, at 3.3 to 13.9. So alarms are occurring all the time, whether those be predictive alarms or glucose alerts. And someone who has this number of alarms is going to quickly stop using CGM because they're not getting benefit from it, and they're getting irritation. We developed a stepwise approach to CGM alarms, which was used in the time trial, again available in our BMC Pediatrics paper. And some of these are trial specific, but many can be applied to individuals starting CGM at any time, whether that be a simultaneous start with pump therapy or adding CGM to an existing insulin regimen. The final message I wanted to make is regarding data management software, which are absolutely essential for success with pump therapy and with CGM. And I can't imagine seeing any patient in clinic and not using data management software and not having them use it at home. At pump initiation, we encourage them and tell them that they need to come to the pump start with CareLink or Diasend already set up with a printout to demonstrate they've got it working. And then they're told they have to upload weekly and before calling or emailing, because that's their logbook. That's what they use for data management. This is what is the only way to get true value out of CGM and also for their pump therapy. And then in clinic, we upload it when they come in, although ideally they've uploaded it home the night before. And we have it available on our server, thanks to our IT support at CHEO, which enables all team members to view and use the uploads during and between clinic appointments. So there are many, many reports within CareLink, and I'm not going to go through all of them, but draw attention to the couple that I find really important and useful in clinic or when someone's contacting me between clinic visits. So this is the adherence report, and on that, the first column is number of glucose readings. So very quickly you can see how often are they checking their blood sugar. In this case, it's 6.7 times per day, so a reasonable frequency. I can see the sensor duration, which was used pretty much 24/7 up until the 3 days prior to coming in, and we can talk about why they stopped for a couple of days there, but was good use prior to that. Look at the frequency of boluses and the fact that bolus wizard is being used and how often they're doing corrections or overriding the bolus. And then look at the number of fill events, which tells me how often they're doing set changes, but also whether they're doing them correctly or not. And then look at suspend duration, which in pediatrics we see lots of times where kids are suspending for sports and other reasons, but in particular can look at those red highlighted areas on that final column, which tells us how often low glucose suspend is occurring and whether that's at a reasonable frequency or not. Then I look at the dashboard, which is a great source of information about general diabetes management, pump therapy, as well as CGM. I can see from the statistics in the upper right corner there, their average glucose, their estimated A1C, which is remarkably accurate compared to the A1C that we get in clinic if they're using CGM consistently, the number of glucose readings again and carbs that they're eating. I can see their total daily dose and their basal and bolus ratio. I can look at the frequency of set changes. And then look at their sensor use, and also importantly, how often alarms are occurring. And if I see they're having a lot of alarms here, I know I've got to change some settings, or they're either for CGM or their pump settings to ensure that they're not having an unacceptable frequency of highs and lows. Then I can look at where they're having highs and lows in terms of patterns, and then drill down in terms of individual meal time and which meals are a problem in terms of when we need to make changes in their ratios or other settings. And then I go to the daily detail. And for me, the daily detail is like a logbook. It's no different than going back to the 2 weeks of logbook readings and seeing what the numbers are like. And I use the daily detail for the same purpose. And we'll scroll through the last 14 days to look for patterns, to look for teachable moments, to enable them to identify what needs to change, what they're doing well, and then where we can make changes to improve control. So here we see an issue where someone's low glucose suspend has been activated during the night, but the blood sugar has risen quite significantly. And it turned out that not only was low glucose suspend activated, but they also treated it with oral carbs. And so it was double treatment, and in reinforcing the importance of it's either or, not both. Then we can look at what's happening post-meals and see that there's issues here with the insulin to carb ratios and needing to make some changes there, and potentially with basals in the late evening with dropping post-bedtime snack. Can also look at times when they're not using CGM and emphasize what's missing on those days. So here's a situation where someone has done in this case 5 glucose checks that day, so not a bad frequency for someone who's on pump. They've got it before each meal and before bed. That's what we ask for. But when I show them this, I say, you're high at breakfast, lunch, and supper, but I have no idea what to change to improve control, and neither do they. The only reading that helps me is that post-supper reading where I can see that that the glucose has dropped, and so that the supper bolus did help to improve, to lower the reading that was high prior to that. I can also look at teachable moments in terms of responding to high sugars. So here's a sugar greater than 22, looks like a missed bolus, can talk about decay prevention and whether injection and set change was done. And so really important teachable moments from that. So take-home messages for me are that SMBG, even if done 10 times per day or more, doesn't enable most of our children and youth to achieve A1C targets, and hypoglycemia remains a limiting factor for many of them. Most, if not all, pump and MDI patients are potential candidates for CGM, and if used consistently, it improves metabolic control and patient-reported outcomes. But success with CGM requires attention to factors that influence adherence, the human and technical factors, education, and ongoing support. And I'll end with a star patient. I showed you patients previously who had some good days and some bad days, and this is one clearly I love all my patients to be doing this well. But the reason I showed you because it demonstrates the potential success that CGM can have. And so here's someone who's been using CGM consistently now with low glucose suspend for more than 2 years. Her estimated A1C on the clinic report is 6.0. She's doing 6 blood glucose checks a day, so very reasonable frequency. She is wearing her sensor pretty much 24/7 and has a reasonable frequency of alarms. So for her, it's not a nuisance factor. But the most impressive thing is that that she's having hypoglycemia, but minimally, and over the course of 2 years achieving remarkable A1Cs, which you can't achieve any other way. A1Cs in the high 5s, low 7s, without any severe hypoglycemia. And that kind of success just isn't possible without CGM. It's certainly not all patients with CGM achieve this, but it's a goal, and many are getting close to this and achieving this, and it certainly is the goal for all of our patients, and with CGM it becomes possible, which is why I encourage you to strive for success with your patients, look at strategies to make it successful with them, and address the elements required for successful CGM use.
That's wonderful. Thank you so much, Dr. Lawson, for that comprehensive and detailed look at CGM. I have a few questions, if that's okay.
Sure.
You mentioned that the literature, we're normally looking at randomized controlled trials generally, and that you feel that prospective research might be a little bit more applicable to diabetes technology. Do you think that that'll change the landscape of what we see published moving forward? Do you think we'll see more of those observational trials that might make a bit more sense for interpretation?
I think so. Increasingly, people have recognized that although RCTs are the gold standards in systematic reviews, that because the technology is changing so quickly, because of the inclusion criteria for those studies, they aren't representative of clinical practice. And we've seen that with pump therapy for years. Yeah. We know that the published studies of pump therapy do not necessarily represent what we see with our patients, that our patients do better than the RCTs should suggest. And the same is coming true with CGM, and particularly because of the rapid advancement in technology.
Exactly. It all moves so quickly. Sometimes by the time we see a publication and we see what's happening in our practice, it's hard to pull it all together.
That's right.
And you also showed us a little bit of data about fear of hypoglycemia. And I'm just wondering if you can comment in your practice, what proportion of your patients and families do feel some fear of hypoglycemia, and whether or not you've seen a proper reduction of that fear, I suppose, when you've applied CGM to those that weren't using it before?
Yeah, I think it's a major factor for our families, and I think it's hard to find a family who isn't afraid of hypoglycemia. For many, they fear that more than hypoglycemia and the risk of complications because it's immediate. Yeah. And they fear going to bed at night and not having their child wake up, or wake up with their child in a seizure. CGM gives them that peace of mind, and for many families what we hear is that they can go to bed at night, not check their child, and know that their child is safe, and will wake up with a sugar that's in control, that starts the day off right, without worrying that they've had that they're at risk of a significant load during the night or during the day at school. Yeah,
it can make a huge impact. And let's say you have a child who doesn't want to wear a second sight. So that's something we hear commonly. How might you open that dialogue with them or the family to get them to be open to wearing that second patch on their body?
Yeah. So that's a tough one, and we know that devices are coming down the road which will be a combined sight, but it's not here yet, and so many families are anxious for that. One of the factors we found is with Enlight and with enhanced Enlight, even more so, the comfort factor is such that the second sight is less of an issue. So it used to be that patients would say to me that the pain with a sensor was up here, and the pain with a discomfort wearing a pump is in here, putting a pump insertion. Now this hasn't changed, but now they tell me that it's the pump insertion that hurts because the CGM is so comfortable, that this seems painful in comparison, even though this hasn't changed. And that's because putting in the Enlight is basically effortless. It's very comfortable to wear. There's not the pain involved. And so once they've tried it, the second sight becomes less of an issue. And particularly, I think, with enhanced Enlight and better adhesive, there'll be less tape issues, and that will decrease that potential barrier of having a second sight. Yeah,
no, that's a great way to frame it. I know those that have tried sensing historically might remember electrodes and needles that were much larger than the ones that we use now. So it has come a long way.
It has.
And the final question I was going to ask is, in terms of physician and educator looking at the CareLink report, sometimes we hear in the community that it takes too long. So I was hoping that maybe you could tell the viewers, how quickly do you think you can be once you're proficient at the reports and interpreting them either with a patient or before you speak to a patient? I mean, I imagine you can do it very proficiently and quickly at this point.
Yeah, certainly for me, a patient on CGM takes no longer than a patient using SMBG. The difference is the quality of the interaction, that I'm actually providing more value because we have information that's much more meaningful. I have up to 288 readings per day and trends and data, as opposed to these arbitrary values of 2, 3, 4 checks a day, which are difficult to interpret, that may have accuracy issues, that may not be done at the right time, and that are very arbitrary. Yeah. And so the time it takes me no more time to see a patient with CGM, but the benefit of that appointment for them and the satisfaction I get from it is much greater because we're actually able to make an impact.
No, that's excellent. And actually, I just have one final question. In terms of accuracy and the second drop, is that something that you would both put into practice now? So for any patient using CGM, do you always educate for that second drop when calibrating? That's a little newer to me, this is wonderful. So I get to learn as well. Whether they're on CGM or not, I recommend second drop for all patients. Yeah. We know the kids are in the clinic with us and they're eating a granola bar or something else, and then they go to check their blood sugar. Well, no wonder you're getting inaccurate results. And I think initially people would look at their SMBG readings and their CGM and think there was a big discrepancy. But in fact, the SMBG was the problem. It wasn't the CGM that was the problem. And if we encourage people to use that second drop all the time, whether they've washed or not, it becomes a habit, and then you're much more likely to get accurate glucose readings. That's a great tip, and certainly was evidenced by the couple of slides you showed on that. So I will certainly be taking that home myself for my CGM trainings. Yeah. So I'd like to thank you again.